because of that results in a small blood vessel constriction and ischemia, which over the years can result in faster degeneration of the spine and more neck issues and back issues.
World of Pain MD podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information on this website or podcast. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome back to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derek Davis, a physician subspecializing in pain management. In this episode, we speak about neck pain with Dr. Mikhail Zhukalin. Dr. Zhukalin was born and raised in Russia, immigrating to the United States at 16. He earned his bachelor's degree in biochemistry with honors from Boise State University before completing his medical education at Des Moines University. Dr. Zhukalin completed his physical medicine and rehabilitation residency at Emory University, where he also served as chief resident from 2014 to 2015. He then pursued an additional year of subspecialty training at Northwestern University in pain medicine before returning to Atlanta to join Emory. Neck pain is a condition nearly all of us have experienced at some point in our lives. From a dull ache due to looking down at our phone for too long, or a sharp pain from sleeping in the wrong position, neck pain is one of the most common musculoskeletal complaints, and it can also affect our everyday lives, but it can be more than a minor inconvenience. It can significantly impact your mobility, your sleep, and your mood, and just your overall well-being. In this episode, we'll delve into some of the intricacies of the anatomy of the neck and explore some common causes of neck pain. We'll also discuss some possible treatment options and some lifestyle adjustments for the neck. As always, thank you so much for watching or listening. I hope you enjoy this episode and learn something. All right, Dr. Zhukalin, welcome to the show, World of Pain MD. Thank you so much for your time, sir.
Thank you for having me. It's a great pleasure. I'm honored.
Yeah, I'm honored. The man of many talents.
This is my first podcast. I've never done a podcast before, so we'll see how it goes.
You're gonna be famous. It's gonna go viral. Dr. Zhukalin, you're gonna be on like accordion tours after this.
Yep.
Singing tours. But I suppose just getting into it, why did you choose the subspecialty pain in the first place?
I didn't know I was gonna go into pain initially, and didn't know I was gonna go into PM&R.
Mm-hmm.
And like many PM&R residents, I didn't know what I wanted to do.
Right.
In medical school, my most favorite subjects were internal medicine and the surgery. And I kept going between those. Mm-hmm. I like peds too, pediatrics. I was kept going between those two. And neither one of them seemed to be like 100% satisfactory. And then when I discovered PM&R, it seemed like a perfect mix of everything. And you can do many different things, different populations, pediatrics, adults, different injuries, interventional, non-interventionals, whatever you want to do. So that's how I ended up in PM&R. And as I was going through PM&R, I liked many subspecialties within the PM&R. My top contenders by PGY3, PGY4 were interventional pain mm-hmm. and the spinal cord injury, of all things. And I was this close of getting into spinal cord injury fellowship. I still find spinal cord injury care very satisfying.
Yeah.
And like the patient population, like to take care of spinal cord patients, and still have a few patients that come to clinic. But ultimately, I had to make a decision. And I decided to do pain. Mainly because of its complexity, the variety of things you can do within the specialty, the fact that It's usually poorly understood. Many people don't know how to treat it, and people end up suffering. And there's more and more emerging techniques, different procedures, different interventions that could be used to help those patients. So once I got into it, I really liked it and never looked back, and still am very happy that I've chosen this field.
Yeah, awesome. It is a great field, and I completely agree with you on all the things you can do within PM&R and the arising techniques for interventional pain. So, that's why I'm going into it, and that's why I started this podcast. Speaking of the complexities of pain, we're talking about neck pain today. Do you have in your mind boxes, categorizations of what causes neck pain? And I suppose we'll talk about treatment, but kind of in terms of how they differ for treatment. What's your approach of first diagnosing different types of neck pain and then treating them?
So the neck pain is very common. It's probably as common as low back pain, a pretty high prevalence. And most people listening to the podcast have experienced at least one episode of neck pain in their lifetime.
Me 2 days ago.
Yeah. And the most common causes of neck pain are something axial, something having to do with muscles, tendons, joints, bones, discs, and so on. Many people have had neck strain. Either they slept wrong, they moved wrong, they picked up something heavy, they turned their neck, or did different things, and that's common. Broadly, it can be subdivided into just axial pain just in the neck without any radiation. That can be either kind of insidious onset or traumatic or after some event. Then you have the category of neck pain that affects something else, like radiating pain to the arms or changes in your strength, the weakness in the arms or legs, or balance issues that we'll talk separately about that. That's another subcategory. So neck pain plus maybe pinching on some nerves or spinal cord or something else going on. And lastly, anytime you see a patient for any pain complaint, you have to think could there be something else? Yes, they're complaining of neck pain, but what about not neck causes of neck pain? So could it be referred pain? So, for example, anterior front of the neck, anterior neck pain is not common presentation. And if you see somebody with anterior pain, could it be something else? Could it be a symptom of cardiac, something like a coronary artery syndrome? Or could it be something that has to do with esophagus or with blood vessels within the vein? Could there be tumor in the thyroid or any glands in the neck? Could it be infection not related to musculoskeletal things? So you have to think about those things as well.
Yeah.
Or referred pain from something else, such as the shoulder, for example, or even internal structures such as lung, most commonly like Pancoast tumor or something like that.
Right. The top of the lung.
Yeah, top of the lung, or other things. So you have to keep it in the back of your mind. It's not common, but if you don't think about these things, you will never be able to diagnose them. So if something seems off, doesn't fit the picture, you have to broaden your differential and consider other things. Otherwise, you'll be missing things.
Have you had a patient come in that's just GERD, like esophageal reflux? Kind of anterior neck pain or anything like that? It's not really.
I've had I had a few cases like that. One patient not too long ago had this neck pain anteriorly, but only happened when he is lying down, but not when he sleeps in the recliner. So we considered the possibility of GERD as well as many other things, and he improved. He ended up putting extra pillows, and he said it's better. So it once in a while you see something like that. Although he did have some arthritis in the neck and whatnot, which is also a common cause.
Got it. Okay. Then speaking of all these categorizations, when you see a patient, do you have a way in which, they say, oh, it's like my neck hurts in the back, it doesn't go down my arms. How do you approach that patient versus a patient that has, my neck hurts and it goes into my hand? How would you differentiate that evaluation, I suppose?
There's pretty much you approach every patient similarly. Before you walk in the room, you look at patient's age, so that gives you a good pre-test differential diagnosis.
Right.
If somebody is 22 years old, you have one set of possibilities in your mind before you even walk in the room. If somebody is 75 years old, then you have different set of common diagnoses. And then you start talking to the patient, you find out where's the pain actually located, what does it feel like, how long they've had it, was there any inciting event, was there trauma, when was the first time they noticed the pain? Is it something that's been going on for years and occasionally flares up, or is it something that just happened a week ago after they fell asleep watching a movie and then woke up with a crick in their neck? So that gives you different ideas of what might be going on. And once you kind of establish the timeline, the history, then you start figuring out what makes it better, what makes it worse, what motions of the neck, if any, make it worse. Is there anything else that might be going on that could be subtle? Any weakness in the arms, changes in grip, changes in balance. Have they noticed anything different with bowel and bladder? Things like that to rule out any red flags.
Yeah.
Fevers, chills, and so on.
Yeah.
Yeah.
When you then get that history and proceed with physical exam, what are some of the physical exam maneuvers that help you rule in, rule out different things for neck pain?
So first, on physical exam, I like to see what patients can do themselves. So it's called active range of motion of the neck. So I have them look up to the ceiling. I have them tuck their chin. I have them side bend to one side and the other side, noting for any asymmetries, any reports of pain or discomfort. Is it ipsilateral side, same side, or contralateral side? That already I'm forming possibilities in my head. Is it just a pulled muscle, or is it a disc, or is it a facet joint? What else might be going on? Looking over the shoulder. And the location of the pain. Is it at the top of the neck, close to the head, the very top of the head? Is it more down and really into the upper trapezius? Do they have any pain in between the shoulder blades and things like that? All of it is axial pain, but it kind of as I'm going through a physical exam and looking at the patient, I'm trying to form possibilities in my head that can change the places as I'm doing the exam, but then help me. Once I'm done with just looking at the patient, I sometimes try to do some of those maneuvers myself to see if I can, where is the end of range of motion with different activities. I do compression, like Sperling test, putting some pressure on gently, and telling the patient, I'm not going to do anything sudden. I'm not going to hurt your neck. I'm going to be very gentle to see if that produces the pain. I do a detailed neurologic exam, which usually includes checking the reflexes for any asymmetries and just to get a sense for any hyperreflexia or hyporeflexia. Then both upper and lower extremities. Then I do the manual muscle testing, which, just to make sure there's no weakness, including grip, proximal muscles, and so on. I do Hoffman test, which is another test for hyperreflexia. I usually have them just walk in the room and maybe check a tandem gait, making sure there's no ataxia or abnormalities with that. And then as I'm doing it, I'm noting overall, how patient reacts with different things, and that helps me. And finally, sensation, feeling the sensation to light touch in all dermatomes of the upper extremities, if needed, lower extremities too, but mainly upper extremities. Then, if there is radiation of the pain to the upper trapezius or the shoulder, it's very pertinent to also do a shoulder exam, which can mimic one another, like
Right.
shoulder pain, neck pain, shoulder pain. And sometimes it's difficult to tease out what's what.
Chicken or the egg sort of thing.
You have to do it.
Yeah. When do you get pushed to follow up with advanced imaging or just X-rays, rather than just relying on your physical exam?
X-rays, I do frequently. In general, X-rays are not needed all the time, especially in primary care setting. But if a patient sees me in the subspecialty tertiary care spine center, in 9 out of 10, they've already had a visit with their primary care or even emergency room and have been referred. And many of them have already had imaging. And if not, I will probably get at least some basic X-rays. Just to get an idea of the underlying bony anatomy, alignment, any suggestions of degenerative disc or arthritic changes, any subtle dislocations like alisthesis and so on. I think that's helpful. If they have history of something underlying condition, I may get an expanded X-rays, not just basic X-rays. For example, if there's history of like rheumatoid arthritis or Down syndrome, I'll get a flexion extension films looking at the any atlantoaxial dissociation between C1 and C2 because it's very commonly involved joint. I may get additional views, including open mouth views to look at the C1 odontoid process. I may get a swimmer's view, especially if I'm suspecting something in the lower cervicothoracic region, and so on. But
the swimmer's is to allow for
allow for lower cervical visualization, which is frequently hidden by overlying structures such as shoulders and such. So it's mostly just basic views, unless there's something underlying. If patient has had cervical surgery, which in my practice is very frequent, then I also get flexion extension views because degenerative changes above and below the surgery are very common. The fused segments and to assess for any dynamic instability and so on. So,
when would you go to advanced imaging, CT versus MRI?
Usually, if there are any quote unquote red flags present on exam, or if in the absence of red flags, the pain persists despite having had all sorts of conservative management and time. Just your example of axial neck pain, no radiation, and initially you usually start with something conservative, maybe some over-the-counter medications, NSAIDs, Tylenol, maybe course of physical therapy, some neck-specific exercises for the patient, education, and you expect this to get better. But what if it doesn't? Like, what if they come back and it's been 6 weeks, 2 months, 3 months, and the pain is not better? Maybe it's even worse. Yes, there's no red flag symptoms, but could it be something else going on? So that's when you start thinking about maybe advanced imaging. If there is any neurologic deficit, weakness in the arm, or changes in gait, changes in balance, then you jump to advanced imaging sooner than later. In terms of advanced imaging, probably MRI is the best in terms of yield for most cases, because it's very detailed and showing discs and nerves in very good detail. There are some instances where CT may be more favorable, like if you're suspecting something with the bones, like a hairline fracture that's not seen, X-rays may be better. If you are, if you want to evaluate the fusion, or bony, has it been spondylosed completely, out of fusion or surgical fusion? Is there any evidence of failure of surgery? Then CT may be favorable, or sometimes both may be needed. Or patients cannot have MRIs for some reason, like they have a pacemaker that's not MRI compatible, or other device, or they've had prior metal in their body, or claustrophobia. People cannot have MRIs because of claustrophobia, and for some people it can be like really bad. And there's some. If I really want an MRI, I've even ordered MRI with anesthesia sedation, where they are put under and have this imaging done, and then go from there.
No open MRIs, though. The resolution, the quality is just
the newer open MRIs are better. I mean, it's fine. I've sent some patients for open MRIs, and they were fine. The imaging quality was actually better than expected. So I'm okay with that. As it's not ideal, but if that takes care of their anxiety and claustrophobia, they feel better doing it. By all means, better than nothing. Yeah.
So we've kind of already mentioned this and touched on these next two questions pretty well, but basically, what are the red flag symptoms? You kind of already alluded to them, said a few, and what are some of the do not miss differentials? And lastly, when should a patient come see you in general for neck pain, I suppose?
So the red flag symptoms, neurological symptoms are, if we're talking about radiculopathy, then radiation to the arm with associated weakness, especially if that is worsening. And that can be challenging to gauge when you're just seeing a patient for the first time and you don't have any idea of temporal progression, and the patient is not aware either. So if I'm worried about it and I want to kind of track it in time, I'll tell patients to do certain things, certain exercises themselves to track it in time. For example, I may tell a patient, do some push-ups against the wall, or if you do a full push-up on the floor, and try to do it once a week just to kind of gauge the strength. And patients are pretty good about that. If it's getting stronger, we can continue to kind of monitor it conservatively and hope for the improvement. But if it's getting worse, then they should let me know right away, and I'll be more aggressive in their treatment. Sometimes it's, especially for strong, people, bodybuilders. I've had a few cases where a bodybuilder comes in, he has a neck pain radiating down the arm, and I'm doing a manual muscle testing, and it's normal, it's fine. And on the face of it, you think, I mean, I don't see any neurologic deficit. But then if you ask them, then they'll tell you, I used to bench press 400 pounds, but for the last 2 weeks, I can barely do 200 pounds. So that's a 50% decline. That's a huge loss of strength. So it's probably legitimate neurologic deficit, but I'm just unable to catch it in my clinic because of the fact that I'm not a bodybuilder.
He's already been treated, or she's already been treated.
So that's radiculopathy. And if it's progressive, if it's weak and it's progressively weaker, then I'm more worried, and I'll have a much I'll be sending him to MRI much quicker and sending him to see a surgeon much quicker. Another thing not to miss is compression of the spinal cord, which is cervical myelopathy. If the spinal cord if it gets compressed, the symptoms can be subtle and may not be obvious, and most importantly, can present without pain. And you have to always be on the lookout for it. People may start complaining of clumsiness in their hands. They cannot grip small objects. They have a hard time buttoning shirts. For women, I asked them how you were able to put your jewelry yourself, or did you struggle with it? And sometimes you'll be surprised. You say, "Oh yeah. Now that you mentioned it, now I used to be really good about putting my necklace on, but now I just cannot do it." And that makes me think like it could be something else going on. Changes in gait and balance. If patients report that they started walking funny, that they're careful. There have had a few times where they almost fell. I have them walk in a tandem gait. If they have issues doing that, I'm more suspicious that it could be something like myelopathy going on. So that warrants additional imaging because it can be fixable. It can be, you can decompress it and have the patients avoid more spinal cord injury. And then other red flags have to do with things like infection. Like if somebody has very stiff neck, cannot turn, severe pain associated with fever and chills, you have to investigate further. Advanced imaging, occasionally even lab work to make sure. If somebody has a history of IV drug use, higher risk. If somebody is immunocompromised, higher risk. If somebody who is on chronic steroids, higher risk. So like all those things you have to think twice about, and you have to be able to act swiftly if you want to find out the underlying problem and help it.
Do you ever sort of acknowledge the yellow flags, like don't like their job, for instance, those psychological factors that sometimes we don't talk about as much?
Yes, there's probably a percentage of patients that have that. It's job dissatisfaction, or in case of car accidents, the hope of some monetary compensation pending litigation. And I'm not shy about asking those kind, not directly, but if they've had a car accident. And maybe it was a couple of years ago, and they're still complaining of neck pain, and they attribute it all to the car accident and whiplash injury, which is possible. Yeah. But my next question is like, has this case been settled? And if the question is, so no, I'm still in litigation, then I'm thinking, could it be issues with secondary gain? Patients are looking. Interestingly, I think there was in general, neck pain has less job absenteeism than low back pain in general. With car accidents, there could be issues related to that. I was, as I was preparing for this, I was reading some up-to-date articles about the neck pain, and there was I think in Australia, they took away, they capped or they took away the compensation for pain and suffering after car accidents for neck pain. Wow. And after they did that, it was a significant reduction of long-term kind of neck issues in patients after car accidents. So I'm sure there's a percentage of patients who have that as underlying factor, but I think it's a minority of patients. I give all patients benefit of the doubt, and I definitely don't want to attribute their complaints as something not real or not medical. But I'm sure there's portion of the patients who have that.
It's inherent to the pain field in general.
Yeah.
Are there specific levels in the cervical spine that you see most commonly contributing to pain?
Statistically, I think mid to lower cervical spine is most involved, from probably C4 vertebra down to C7. The C5, C6 is common, and the nerves being affected are C5 through C7. Like if you were to have a pinched nerve or radicular pain or radiculopathy. However, if with certain complaints and certain age and certain underlying diagnosis, other levels could be important. For example, once again, rheumatoid arthritis, then the C1, C2, like and the cervical rotation will cause pain. If somebody has a Chiari malformation, that's different. It's higher in the neck too. So, but in most cases, it's mid to lower cervical spine.
Is that where you get the most rotation, or you get the most flexion and extension?
The rotation. 50% of rotation happens at C1, C2, and other 50% is spread over the lower cervical levels. With flexion extension, most of it happens in the mid to lower cervical levels, and part of it happens at C0, C1.
Okay.
I think 1/3 there and 2/3 in the rest of the neck. So with the most common cervical levels affected, that would mostly involve cervical flexion extension and also cervical side bending. Okay. So those are what I'm looking for.
And then speaking of bending and flexion and rotation, how does posture and ergonomics affect pain? And do you give people adjustments that, kind of question, are they holding their phone down like this all the time, and maybe to ask for different adjustments they should do throughout the day?
Yes. Yes. That's a short.
Yes, it's just the answer.
That's the short answer. The long answer, you have to get an idea. I always ask patients what they do for a living. Is it a computer work? Do they sit all the time at a desk? Or are they a truck driver? Or maybe they work at a warehouse? Or maybe they do something else, just gauge the stress that their neck is under day to day. Computer work and sitting in a poor posture, probably like I'm sitting right now.
Same here.
That does put more strain on the neck. Looking at the cell phone all day long, or like many people doing these days, that's probably putting strain on the neck. Flexion puts more pressure on the discs that's anteriorly, and also strains the muscles that are posterior. So that can be a cause of neck pain. Alignment-wise, normally you would see a little cervical lordosis that's considered "quote unquote" normal, but you can see straightening of the cervical lordosis, or even reversal of the cervical lordosis, which may be pathologic, but may not be also, because many people with straightening cervical lordosis don't have any symptoms. But if it's associated with complaints of pain and with their ergonomics, you think maybe it's something that's related. So you have to take it in context. And as far as interventions, I talk to them about proper positioning. So if they're working on the computer, ideally you'd have your monitor elevated slightly higher, so they're more eye level, and when you sit in neutral position, and the neck is not looking down all the time, and be cognizant of it. Frequently, especially with desk workers, other muscles become either too tight or too weak. Commonly, pectoralis and pec minor, pec major get more tight. Shoulders get rolled forward. The muscles in the upper back and periscapular region between the shoulder blades get weak, and as a result, we have this common stooped forward posture, rolled forward shoulders, the less support for the neck, more strain of the neck muscles. To fix it, you do the opposite. You stretch the muscles that tend to get tight. You strengthen the muscles that tend to get weak. You adjust your ergonomics. You strengthen the neck muscles to be able to withstand the load that's put on them. And that's the goal of physical therapy and the goal of home exercise program, which I frequently give. Almost every time I give to patients some form of exercises that I think will be helpful to them.
Are those like kind of extension exercises, or maybe some like scapular retraction exercises?
So working on the kind of upper back, shoulder girdle, combination of stretching the anterior muscle, strengthening the posterior muscles, maybe with some bands. Then working on neck range of motion and stretching in different direction. Working on so-called chin pecs, which strengthen the deep stabilizing muscles of the neck. Some people find cervical traction helpful, which I recommend quite a bit if there's no contraindications to it. From personal experience, I know that it works really good.
Even with radicular symptoms typically?
Yeah, sometimes it can help with radicular, depending on underlying etiology or radicular symptoms. If it's a soft disc herniation or a tight neural foramen, some gentle cervical traction may help, either in physical therapy or some people even get like home cervical traction units.
Right, yeah, I've seen those and I know patients have spoken about them before.
Yeah.
How does your approach to management of pain differ when it's chronic versus acute? Kind of that 3-month mark, 6-month mark. How do you change your management at that point in time?
So first of all, the pain has been persistent for a long time and it's more in the chronic category. It probably at some point warrants advanced imaging just to see assess the anatomy, see what's going on, and to see if you were to do an intervention on the neck, what would it be? So that's first of all, you have to get your kind of basic information and basic anatomy. Then you talk to the patient and see over the time that they've had this pain, what worked, what didn't work, what made the pain worse. Are there certain medication, maybe certain physical therapy things that seem to help, and how good are they about keeping up during exercises and things like that. Once you get that under control, then you figure out, okay, the pain is still there, like what can you do to help with the chronic pain? I mean, do you have to do an injection in the neck? If so, like, do you have to do ablation for set-mediated pain? Do you send them to a surgeon? Surgical referrals, usually, if it's more neural compromise of some sort, so either radiculopathy or myelopathy, surgery for axial symptoms, axial neck pain is more of an iffy proposition. Sometimes patients really want to see a surgeon, and I'm like, okay, fine, and I'll give them. We have excellent surgeons, and I tell them, good surgeon will talk you out of surgery if they don't think it's inappropriate. Fortunately, our surgeons are very good here, and I trust their opinion, and the patients seem to respond well to their advice.
Yeah. Okay. What patients do you typically see? What's an average patient for you in terms of what they present with? And I suppose just more generally, is there a certain demographic that is more prone to neck pain? And I think you had mentioned some already, people that are kind of in a seated, poor posture for long periods of time, maybe truck drivers, unless, I even have really bad posture, just even talking about posture. But is there a certain demographic you see?
Across the board. You see if it's more arthritic pain and more kind of older population, 50 plus, then you think of arthritic pain. If it's more acute pain after like a whiplash injury or somebody got rear-ended, it's across the board. It can be a young person or an older person. So different age groups present with varying underlying pathologies, but like neck pain is so common that you can see 3 patients back to back, and one can be 22-year-old, and the next one is 80-year-old, and then next one 50-year-old, and they all have neck pain.
When you prescribe physical therapy for neck pain, are there certain things you write on I think PM&R is pretty good about giving specific exercises, and we just spoke about some of them now anyways, but are there specific things you write depending on what the etiology of the pain is?
I try to be very specific with physical therapy, and I try to kind of fine-tune my prescription to individual patient. If beyond just a regular evaluate and treat, you can add, if there's a significant myofascial component or tight muscles, I may add a deep tissue massage, myofascial release, or dry needling. If there's a concern for like a pinched nerve or something, I may add a trial of traction. If there's a concern for just deconditioning, I may add specific instruction to work on specific muscles for conditioning and improving the posture. Occasionally, I've even ordered formal ergonomic evaluation, especially if it's a work-related thing, and that may help. And many employers, especially like bigger companies, will accommodate if there's a specific ergonomic setup that's recommended. And some physical therapy locations will offer ergonomic evaluation, and some jobs, once again, probably bigger companies may have that option as well. So that's helpful.
And speaking of different specialties we work with, I just wanted to jump back real quickly about when we refer to surgery. When you refer to surgery, obviously some of the things that we discussed, like those do not miss things, like difficulty with fine motor tasks, some difficulty with ambulation. When do you typically find yourself referring to surgery? And because I struggle with sometimes understanding when I would refer to surgery, because they have a radiculitis component, a radiculopathy, and they have some weakness, asymmetrical weakness. So when do you sort of switch to saying, okay, let's just talk to a surgeon now?
It's helpful to have some sense of temporal progression. So if you have only one point in time and you're seeing a patient, it could be difficult to make that decision. So if you're on the fence and if you cannot make a decision, it might not be wrong to have a quick follow-up within a couple of weeks, 2 to 4 weeks, just to reassess. And then you have 2 points in time, and then you'll probably have a better, feel better about either referring or not referring. So that's one thing. Second thing is, like, depending on the amount of neurologic deficit, if it's really weak, I can just, sometimes I just refer right away. If it's slightly weak, I like we talked about, I educate the patients, like, okay, these are the muscles that are more likely affected in your case. Can you do me a favor and monitor those muscles over the next few weeks, and let me know if you feel that the muscles are getting weaker. If that's the case, I'll probably refer to see a surgeon. With the cervical myelopathy being sometimes painless, as I mentioned, that conversation can be even more challenging. I had one patient a few years ago, guy in his 40s or early 50s, came in, could barely walk because he was so ataxic, and he wasn't sure why he was there. He's like, "Oh, I had some neck pain; it's not there anymore." But very hyperreflexive, could not walk, and clinically, it was really bad myelopathy. In that case, I actually ended up talking to a spine surgeon in clinic, and between the two of us, we made the decision to direct admit patient to a spine hospital. He did not want to do it. He's like, "I have no pain. What are you talking about? I'm gonna just go back and get in my truck." The only trouble he had was getting out of his truck. And here, like, from Georgia, he's like, "I got to go to work tomorrow. I gotta, I don't have time. I don't have time for this nonsense." So I had a really hard time convincing him. So long story short, he ended up undergoing cervical decompression the next day because he really needed it. That's exception rather than the rule. You don't usually see something that bad that walks into your clinic. So in many cases, the decision is not straightforward initially, but then as you get more information, you either feel better about referring to a surgeon or you decide that it's not really needed.
We spoke about this already, but what are some of the lifestyle factors that affect patients that develop neck pain? And by talking about it earlier, we kind of talked about posture, ergonomics, what you do day to day, but are there anything else? Is there anything else like diet or anything you find that's been helpful or been deleterious for patients?
Diet is probably helpful. There's some evidence that if you have healthier diet that is rich in plants and fiber and less fats and fast food and all that stuff. We know all the good stuff. Yeah. Then people who eat healthier tend to have better spines.
Okay.
The discs are better hydrated and less prone to degeneration. They tend to get healthier spines later in life, less degenerative changes. Obesity, lack of physical activity, same thing. If you're not engaged in some sort of moderate physical activity a few times a week, you may not be doing the body a favor, because then you have a worse cardiovascular health, and as a result, less blood supply to the vital structures, the bones, discs, and what have you. Smoking is bad. Don't do it, because of that results in a small blood vessel constriction and ischemia, which over the years can result in faster degeneration of the spine and more neck issues and back issues. So in general, healthier diet, ideally plant-based. Not necessarily, you don't have to be vegan or vegetarian. Just make sure you get a lot of fruits, vegetables, salads, and good stuff. Then regular physical activity. Every week. Avoid sedentary lifestyle, just take care of yourself. Don't smoke.
Makes sense.
Yeah.
What alternative therapies or over-the-counter medications do you find are helpful? And then when those are not helpful, are there any other medications you reach out to? We discussed gabapentin quite a bit. What about like TCAs, SNRIs? And then lastly, I know it's a long question, but is there any role for narcotics in neck pain?
Starting with the over-the-counter can be very helpful. NSAIDs, ibuprofen, naproxen, you can get them over the counter. If there's no contraindications, that's a reasonable starting point. Tylenol works well and is the medication of choice for anybody over the age of 65 as the initial treatment option. Kind of gentler on the kidneys and less cardiovascular risk. And once again, if there's no contraindications, such as like liver disease, then we go into prescription medications, which is a wide variety, starting from different NSAIDs. Some are more COX-1 versus COX-2 selective. Once again, you have to take it in context of other comorbidities, other health conditions, and if that's an appropriate next step. Neuropathic pain medications such as gabapentin, pregabalin, TCAs. That's for anybody who has nerve pain, like radiating pain in radicular or otherwise. Then you have muscle relaxers that can be helpful, especially for acute injuries like muscle spasm. You probably don't want to stay on them long term. And if they're helping, great. If they're not helping, I don't feel bad just stopping them. It's not a big deal. You can try to. They're all about the same. I usually, if I am prescribing muscle relaxer, I am basing it on patient's age, other medications, and other comorbidities. If somebody is on a antidepressant, then maybe not Flexeril, because Flexeril is structurally similar to amitriptylines, TCA, so that theoretically there is a risk of interaction. Right. If they have issues with blood pressure, especially with hypotension, orthostatic hypotension, or they're on several blood pressure medications, maybe not tizanidine, because tizanidine can drop your blood pressure, especially in people who are prone to it. So on. I'm okay with muscle relaxers, but each patient is unique, and I approach it differently. Narcotic pain medications for acute severe pain may be appropriate. Patient is not sleeping, pain is miserable, and it can be very severe. Then the short course of narcotics may be appropriate, but you have to be careful. You have to always check outside prescriptions, like make sure it's not a patient who's been getting a lot of narcotics. Otherwise, trying to get more from you. Ideally, you want to do it for just a few days until the pain is a little bit better, and then you transfer. But in some cases, that's appropriate, and it's fine.
What about acupuncture? And then I was going to ask you about chiropractors and chiropractic neck adjustments, whether or not you recommend those, because we're in the C-spine here. It's kind of like a controversial topic, it seems. And should people pop their necks? I feel like people probably ask you that. I pop my neck sometimes.
So the risk with chiropractor adjustments, even with high velocity manipulation, are low. When patients ask me that, my answer usually is, I'm okay if they want to try it, and if it helps, fine. I mean, it may help somewhat, and some patients swear by it, so I'm okay. Some chiropractors are actually quite good, and they know what they're doing, and they're appropriately kind of gentle and don't rush to things. Occasionally, if patient is asking you, you want to have specific restrictions what not to do. If somebody has a history of osteoporosis, rheumatoid arthritis, or other conditions, probably high velocity manipulation is not a good idea. If somebody for any sort of like infection, of course, you wouldn't do anything like that. If somebody has carotid artery disease with known stenosis or prior history of endarterectomy, may not be a good idea to do high velocity manipulation. However, like gentle manipulation, myofascial work might be appropriate. Chiropractors are not only about popping necks, and the good chiropractors will know what to do, what not to do. Sure. But it's pretty much comes down to patient education. Like, if you this is what you should do, or you can try it, but this is what you probably shouldn't do given your condition, just to make sure you don't make it worse.
Yeah. How does neck pain overall affect quality of life that you've noticed? Because I spoke to Dr. Olafade, and one of the things is some grandparents will be like, oh, my lower back pain hurts so bad I can't pick up my grandkid. They can't return to work. They become depressed. So what do you see? Similar things in your clinic as well?
Yeah. Neck pain can be quite debilitating, right. And it can not only affect somebody's quality of life, but also safety. If somebody cannot turn their neck to look for a blind spot in the car, that's a problem, because they probably won't do it because it hurts. Right. And then next thing you know, they're in a car accident, and so that's actually a safety concern. It can be quite debilitating, and then if that's the case, you may need to be more aggressive, trying to figure out A, what's going on, and B, what can be done to fix it and help it.
Yeah, that makes sense. Are there any new emerging technologies, treatments out there that you're excited about or that you've seen?
There's potentially. There's a lot of talk about regenerative medicine and PRP and stem cells, and I think that's a promising field, potentially with bright future. The evidence is pretty low right now. There's not good evidence unless I'm not aware of something cool and exciting. Your prior guest, Chris Williams, would be better.
Right. I'll talk to Dr. Miriam Jerome next week.
Yeah, she'd be more versed in the emerging regenerative medicine techniques. Right. But in theory, that may make sense. For example, in the setting of chronic whiplash injuries, which we don't understand very well, but high resolution MRIs did show issues with ligaments and muscles and the tendons in the neck following whiplash injuries, including microfractures, micro tears, and even decrease in vascularization of those structures, which may be why we have such a hard time dealing with chronic whiplash injuries. What if something can be done to reverse that or to make it better? I mean, that would be cool.
Yeah.
As far as other treatments, different injections, different targets are also always being investigated and tried. Different nerve blocks, like medial branch blocks, ablations. That's not really new or emerging. It's pretty well established. But targeting different joints like C0, C1 joint or C1, C2 joint, which can be very beneficial for the right patient, but not as frequently done because it's more risky procedure, and some providers. So even interventionalists will not do those injections. In our practice, there's only a handful of interventionalists that will do even C1, C2 injections, and I'm not even talking about C0, C1. So that's if somebody is well trained and knows how to do those things, that's a good resource to have.
Yeah. Then two more questions here. The concept of central sensitization has been coming up, for me at least, more often. And I was wondering if you could speak a little bit about that in regards to how you see it affecting chronic neck pain, and then more general just pain. Have you seen patients that you think fit a diagnosis of central sensitization?
Probably yes. Yes, I think it's probably not as frequently diagnosed verbatim, just like that, central sensitization. It probably does happen, especially with chronic conditions, chronic radiculopathy or chronic neck pain. Our central nervous system is adaptable and modifiable, and it seems like it can get into this loop of self-perpetuating pain where every movement is interpreted as pain, and everything becomes painful, and that starts affecting the quality of life, and it starts affecting muscles, and everything it just hurts. And that probably is part of it is central sensitization. How that happens and how it works is not well understood. And how to break that cycle is also not a trivial task, but it can be attempted. Once you realize what's going on, you can attempt both physical therapy, medication management, pain psychology, fear avoidance behavior, pain catastrophizing. Those are all the kind of subtle telltale signs that may suggest that patient is having something more than just an anatomical disruption, and other interventions may be pertinent. In that neuromodulation we talked about emerging therapies. That's another possible intervention. Obviously not first line. I've personally had a patient a few years ago who was involved in a car accident with clear, initially, what seemed like clear radicular pain. So neck pain going down the arm, so on the surface, cervical radiculitis or radicular pain. The neck MRI was actually fine. It was unremarkable. No significant disc herniations, no neural impingement. EMG was not very revealing in the upper extremity, but pain was getting worse, and almost to the point where at some point I started suspecting possibility of CRPS in the upper extremity. It was subtle. It was not like end stage CRPS sometimes that you see, but it was a hyperalgesia, maybe color changes, like very subtle signs which made me think something else is going on. So finally we ended up doing a brachial plexus MRI. And lo and behold, it showed MRI evidence of a likely history of traction injury to the brachial plexus. And if I recall that the car accident involved side impact, which likely jerked the neck to the side, putting traction on the brachial plexus, which then set everything in motion, and other things, interventions aiming at the neck weren't working. So after trying everything else, I ended up actually doing spinal cord stimulator trial and subsequent implant to the cervical spine, which I've only done a handful of times because it's not a common indication for it. But the patient did really well with near complete resolution of the pain. So that in that particular case, after failed multiple medications, physical therapy, a long time in pain, even strong pain medications, the spinal cord stimulator did the trick in that particular case. Yeah. And I just saw a patient a couple of months ago. She came in. I haven't seen her for years. She came back for leg pain. And I'm like, well, how's your neck? Well, my neck has been great. So all these years, 5-6 years ago, she's still doing great. So that's a success.
Wow,
so,
that's huge success.
Yeah. Do I think there was some degree of central sensitization going on? I think so, because it was worsening. It started looking like CRPS-ish. And something needed to be done in order to reverse it. So does it work like this all the time? Probably not. But once again, you have to think about it, including central sensitization, because if you don't know it exists or you don't think about it, you will never be able to diagnose it. And if you're never able to diagnose it, you will never be able to treat it.
Yeah. And just one more question regarding that. Do you find yourself referring to pain psychologists often? Or at all?
Not as often as I should.
They're not very frequent. It's not a large population of pain psychologists out there.
Exactly. And the main limitation is the scarcity of pain psychologists. Right. In a perfect world, we would have 1 or 2 pain psychologists on staff, and you would refer patients to them, and you can have a team that takes care of those patients. Very few places have that luxury, and I do consider it a luxury to have something like that available.
Absolutely.
Otherwise, you have to seek the people outside of the practice, and then you have different issues like insurance may not be accepted there, or it may be a ways away for the patient to get there, or if they do get there, then the care is kind of fragmented and not centralized. So that's you do the best you can, but I probably should be referring more to some patients, and I do sometimes, I've referred a handful of patients to pain psychologists, for treatment of central sensitization chronic pain.
Yeah, I'm sure it can be expensive for them as well.
Yeah,
I know how insurance.
Yeah, exactly. And sometimes insurance doesn't approve it, and the out-of-pocket costs are very prohibitive, and the patient ends up being like lost to follow-up kind of thing, and then you wonder what happened.
And the last question. For people listening, watching right now that are experiencing neck pain, what advice would you give them?
Take care of yourself.
Just go to the doctor. Don't do anything I wouldn't do.
That's fair. Be careful with any activities that unnecessarily compromise the neck, such as diving from high altitudes for fun when you have not been diving much in your life, or doing stupid things like stunts or something. So that's obvious. Be careful. Be mindful of your posture. Work out regularly. You don't have to be an athlete, just going for a brisk walk, or doing some light exercise with light weights, going to a pool to do some swimming, doing yoga, or whatever you're into. But stay active, engage your body, and this will help you in the long run. If you do develop neck pain, then you can try over-the-counter medications. You can try some stretches yourself. You can try applying heat, ice, and so on. If it doesn't get better or gets worse, then see a specialist. It might be worthwhile to see a regular doctor is fine initially, just to make sure you get checked out. If the symptoms persist, then see a dedicated spine specialist for more in-depth evaluation and deeper dive into the neck pain.
Excellent. Dr. Zhukalin, the man of many talents and been around the world, lived in multiple countries. Thank you so much for your time. I really appreciate it.
Hey, Derek, my pleasure. Thanks for inviting me.
Thanks, Derek.